Matthew.
Huh?
Want to make babies?
I make already. It's you.
This is Mission Ignite. What's up, dog? Hi, welcome to another episode of What's Up Doc, brought to you by Mission Ignite. Here is where we peel back the curtains of medical mystery and deep dive with doctors from every corner of the healthcare universe. Here, we are not just talking about health, we are living it, learning it, where we get insiders' insights that you can apply directly to your life. It's not just talk, it's your gateway to a healthier life. So let's decode the secrets of health together.
So today's guest isn't just helping dreams come true. He's literally helping families begin. We are joined by Dr. Roland Chieng, the founding medical director of Virtus Fertility Centre, Singapore. It's a pioneer in fertility medicine with over 2 decades of experience in helping hopeful parents across the region. Whether it's IVF, ICSI, or even TCM, Dr. Roland blends innovation, care, and heart in every consultation.
So, whether or not you are fertility curious, planning a family, or just fascinated by what science can do today, this episode is going to open up your mind and maybe even your heart. So let's welcome the man behind thousands of tiny miracles, Dr. Roland!
Hi. Very happy to be here today.
Thank you very much for coming, right? Can you share with our audience out there who you are?
I'm Roland Chieng. I'm now the current medical director of Virtus Fertility, Virtus IVF Centre. I started off as training in Singapore General Hospital. That was many years back in the 1990s.
Wow, that's a long time back.
And we all started off training as a OB/GYN, meaning we deal with women diseases as well as deliveries and maternity.
Okay.
And then for this field, there are quite a few subspecialties. So one of the subspecialties is into infertility. So I started that along that line. And even before I started a private practice, that was in 2010, I was already very much into IVF and reproductive work. So I started my private practice in 2010. I started off my first IVF center in Parkway East Hospital. Mm-hmm. And then subsequently, I went on to Sincere IVF Center. And we moved on to start off Virtus Fertility Center. That was in 2015.
Right? 10 years anniversary this year.
Exactly. So we just had our 10-year anniversary celebration, I think 3 months back.
Congrats on that.
Congrats. Yeah.
So just now you mentioned, that you started off the field of infertility. So many fields. Why this field?
At the time, it was just quite a interesting field because in the process of our training, during the training and all that, I think a lot of us who are doing OB/GYN, we are mostly very much into delivering babies, making sure that pregnant mothers are okay, pregnancy follow-up all okay. Mm-hmm. But I start to wonder, whether there is anything more to this, because every time when they come, they are already pregnant. Yeah. So that's when we realized that under infertility, there is just such a huge area that remained to be tapped. So there was quite a lot of because that was back in year 2000. Year 2000, for the last 25 years, I think a lot of development has gone into IVF progress and leaps and bounds of IVF technologies. Yeah. So it is a lot of development that attracted myself at the time.
Right. So what got you interested in starting off your own clinic, or rather with Virtus himself?
Well, initially that was really just to be able to start off an IVF center, mm-hmm. whereby I could decide on what is best for our patient and best for the success rate. So that was I should say that was the main motivation.
So in case the audience are out there wondering, right? So prior before this recording, we have a private chat with Dr. Roland, right? Dr. Liao, right? If you don't know who Dr. Liao is, you can check it out at the other podcast, right? But that said, I think there were a lot more that you were hoping to achieve with the current setup, right? What was it?
Well, I think initially when we first started, together with Dr. Liao and the rest of the people who started our initial journey, our primary objective was something very simple. We want to set out a center whereby our success rate can be high. At the same time, from experience, the success rate tends to fluctuate. So we want to make sure that success rate could be maintained. And then the next one is that we want the center to be safe. So those are the three main things that we're focusing on. And I think the first objective of having a high success rate is, of course, important. I mean, whoever who started any fertility treatment, I think naturally what we want to achieve is be able to have highest possible success rate, chances of success. Second, to maintain the success rate, I think from my experience looking at IVF centers and all that, IVF center success rate tends to fluctuate a lot. So we want to look into this, and especially on the laboratory side, to do as much as we can to look at all the details, to iron out all the details to make sure that the success rate could be maintained. I think it's only fair patient A come to see me because of certain success rate, and I need to be able to give her back.
Yes.
That the success rate, yes, indeed, is what you are looking for. Yeah. And the third thing, of course, the safety is of utmost importance too.
Definitely.
So when you mean success rate, right, what are some of the indicators that we're talking about? Because I think various centers they publish different kind of performance indicators.
Correct.
Yeah.
So that is probably one of the most difficult area because, you need to be able to compare apples to apples and oranges to oranges, because if you are comparing something else, they are not of the same thing, then you are not really seeing the real picture. Yeah. So there are two main things that we're looking at. Number one is, of course, the clinical pregnancy rate, whereby when you are positive and you have a heart rate, clinical pregnancy rate, then the other figures that most people will be looking at will be what is your chances of having a live birth. And both of these success rate, clinical pregnancy rate per embryo transfer and live birth rate per embryo transfer. So those are the two main ways how we are going to we have presented our success rate.
So per embryo transfer, the definition is the transfer, right? Not
Correct.
the entire cycle.
No. So each time when you have an embryo for transfer, so you transfer one time, and what is the success rate?
But there will be, are there clinics that will share, entire cycle and all?
So there are another way of presenting will be, there are some centers that also presented as what is your success rate per cycle started.
And cycle means extraction of all the eggs.
When you started your first injection.
Ah.
So naturally, the success rate will be much lower because there will be some of these couples who never get to go through egg collection even. Because halfway through, the response is poor. You do not produce any eggs, no egg collection done. So this is also considered part of the denominator. Yeah.
So I sort of break down this part into two big segments here, right? The first segment is actually who are the people that requires IVF, or who are the people that requires to seek your consultation. That's part one, right? And the second part later on, right, will be pretty much what's the whole process of the whole IVF.
Yeah.
So first question, so who are the people that should look for you?
Well, IVF has been around now more than 50 years. So over the years, the way how we look at we approach IVF is a bit different. So naturally, when you look at the process of IVF, in summary, what it takes is that we extract eggs from the ovary, we fertilize outside the body. That means we put the sperm into the eggs, and then wait for it to grow nicely into embryos, and then we transfer back to the uterus.
Right.
So by doing that, you are actually bypassing the fallopian tube. So we always say the IVF laboratory is a more...
The fallopian tube, the mechanical fallopian tube, is it?
Mechanical fallopian tube.
Yeah.
Yeah. So that's how amazing. So that was actually the first generation of IVF, because at that time they will pick out the eggs, and then they will put the sperm in, and then they will give it there overnight. Next morning, the embryologist will come by and check and see how many of the eggs that were there had been fertilized. So that was what we call the conventional IVF process. So naturally, that's the first indication of IVF, when you have fallopian tube disorder.
Okay.
Okay.
Now, thereafter, it doesn't solve all the problem because it only solves the problem of fallopian tubes. Let's say you have tube damage because of previous operation, previous infection. Well, nice and good. IVF will be able to overcome it. But then again, after that, we start to see there are so many patients who start to have sperm abnormality. So sperm abnormality could be in the form of low count, sperm can't function very well, can't fertilize on its own. You use the conventional method, it's not going to work. So that's when the first ICSI, basically means micro injection of the sperm directly into the eggs, was started. So the first case was done in 1997. And that's when they found that the success rate actually is there. That means it's possible. So that's when the second indication of IVF started, when you have sperm abnormality.
Okay.
Now, thereafter, IVF carried on for many years. But now, with rapid development, Singapore, now we are first world. People, stress less important on having sexual activity. They are more on social media, more on TikTok. So that's when we start to look at what other indications. So a lot of my patients now are simply just trying for too long without success. Now, how long is too long?
Yes.
I would say a committed couple, if you have been trying for 6 months, I think sometimes to a lot of people that will be way too long. Because after 6 months, a lot of people will start to shy away. And men are being men. We want to see result.
Yeah.
Fair enough.
The moment things doesn't work, then you start to, I want to get something done. So that's indication number 3.
Right.
Number 4 indications is also getting more and more frequent with this starting of egg freezing. Now, egg freezing, we've been fighting for so long. Now, egg freezing has been around for a while. And in fact, for the last few years, the egg freezing method has, again, there's a major revolution, improved so much, whereby previously we are looking at, 1 to 2% survival after thawing, after freeze and thaw. But now the success rate after freeze and thaw for frozen eggs could be as high as 80 to 100%.
Wow, okay.
So that's why, this is the main reason why egg freezing has come in. But people talk about egg freezing at the same time. For us in IVF, we start to look at, you see, the number of, the age of our ladies who have their first pregnancy is increasing all the time.
Yes.
Yeah, first pregnancy, first time mother, they are getting older and older. Now, all of us could be coming from multiple, siblings.
Yeah.
I have 8 siblings.
Wow. Wow, that's a lot.
Okay.
So if you look at it, let's say you have your first child at 37 or 37 years old. By the time you start looking at your number 2, number 3, you could be way 40 or over 40.
Yes.
So I think that will be the 4th indication. If you can do your IVF, freeze your embryos, and these embryos will forever be available to use in the future.
And that's basically freezing it at the age of which you extracted it.
Exactly.
Yeah.
So,
Also, I want to ask a question on that later on, right? But walk us through, right, the whole process of the IVF. As a patient coming in, maybe trying for 6 months and all. What's the whole process like?
Right.
The whole journey.
So the first step, of course, there are a lot of preparation and all that. So basically, preparation, we just want to know what are the things to expect. We basically need to make sure that their eggs are available. We want to make sure that the sperms are reasonable so that we can, choose the right sperm, put the sperm together with the eggs. So the first step of IVF, in fact, is what we call stimulation for the egg growth. So we follow by the menstrual cycle. So when you started, at the time when you are having your menses, that's when the eggs are starting to grow. Now, the growing of the follicles, which contain an egg, is not so straightforward. In the beginning, there is this process called recruitment.
Recruitment?
Yes.
Yeah, recruiting the eggs.
Recruitment of the follicles to grow. So somebody who have a normal ovary reserve will probably recruit 10 to 20 follicles.
Okay.
One shot.
Okay.
And they will all start to grow. And by the time they reach halfway through the initial 14 days, halfway through, only one will continue to grow, what we call the leading follicles or Graafian follicles, and all the rest will disappear. Right? So people were asking this usual question: what if I do not have any ovulation? Do I have better egg reserves?
Yeah.
When you're closing to menopause. So that's why you might be seeing only one follicle per month, but that doesn't mean that your eggs are being kept.
Right.
They are still being used. Now, when it comes to IVF process, because we cannot be relying on just one single follicle, so that's when these medications will be necessary. So your body will produce your FSH, which induce the follicles to grow. But if you do not have any external or additional level of FSH, there's only one follicle will mature. So by giving you slightly more medication, then all those follicles that are being recruited to grow will all mature.
So this medication, is it an oral injection?
Unfortunately, they cannot be administered orally. It has to be through injection.
Injections?
Yes.
So every day go to the clinic?
So our patients are all very good because the development in this area has been leaps and bounds again. So from those days of intramuscular, whereby you check your injections into a bedside, which is very painful.
Yeah.
But now we have moved on to, injection under the skin. So the injection, we always say that it's just like, somebody who has diabetes, they have to inject insulin.
A small little prick.
A small
prick,
little prick, just pinch your skin, you pinch your, belly, inject, and then, that's how you do your injection.
Right.
So nearly 100% of our patients are all having it done at home themselves.
On their own.
Yeah.
So what comes after that then?
Okay, so once the injections are started, usually over the span of next 10 days, so during this period, they will come to the clinic at maybe another twice or 3 times, basically just to have a scan. We want to see the size of the follicle. And sometimes they need to see the blood test. We also want to see the hormone progress. So once the follicles are up to a certain size, we say, okay, it's ready. So normally it's about 10 days of injection. So once 10 days of injection is up, we say, okay, we are ready. Then we give the final trigger. It's called trigger injection to mature the eggs. And then we organize for egg collection.
That's a lot of needles, man.
Probably about 10 days of 1 or 2 injections per day.
Right.
Yeah, it's usually one time in the morning and one time
Correct.
in the evening.
Yeah.
So we do that all the time.
Yeah, so different clinics might have different routine. So for us, we always prefer to have it in the morning, early morning. So you wake up, before shower, after shower, up to you. So you can have your injection.
Yeah.
Then after that, you get ready to go to work. Then you never need to carry your medication and all that.
Yeah.
Which must be in a chilled environment,
Correct,
right? Yeah.
correct. So we usually advise to be in the fridge. And then when you come back home, and that's when, when the time comes for your second injection, and that's when we advise for second injection before you sleep. So if you're worried that people might get to know what you're doing, and
They won't know because it's very discreet and all.
correct.
Right.
So gone are the days whereby you got to carry around the ice box with your
ice
medication.
pack. Yeah.
So times are very different. IVF now is a lot easier.
So most people would think that the preparation is just this, but I think it goes a few months before. It's not immediate, right? Yeah. So I think some people will start to think, hey, how do I prepare myself for the procedure, and what are your recommendations?
So generally, the advice is that as long as you have your healthy lifestyles and all that, it will be good. But
Healthy, very subjective.
Yeah, that is not really my emphasis. I never really emphasize to them that, you must have a healthy lifestyle for 3 months before you start off. Because I think human body, that's the wonderful thing about human body, we adapt
Very fast.
very, very good.
Okay.
Very, very well. So no matter what type of lifestyle you are, it might deem unhealthy, but your body has adapted. Yeah. So I do not really advise my patient to have any much preparation. In fact, whatever preparation that I want to have is really just to make sure what to expect for me, like how many eggs I'll be expecting, and also what type of sperm conditions that I'll be expecting. So my focus here is really because this is my area and I got to make sure that the number of eggs, the best condition is presented to the lab. And also for the men, the best condition of the sperm is presented to the lab so that they could create their magic.
So when you talk about best condition, now I'm curious,
Yes.
right? Okay. First we talk about best condition, we talk about people smoking, drinking, all these things. All this will affect.
Certainly.
Yes?
Now, the truth is, the effect will be there. But whether it is sufficient to make a difference or not, that is the one that, is going to be quite variable from individual to individual. Now, for egg condition, eggs is different from the sperm. Because if you look at the eggs, they are usually, that size. But sperm is just a small little one speck of it. So eggs, the DNA part of the eggs are always very well protected. They have a huge amount of fluid, liquids around it, neutralize, dilute whatever toxins that might come by. All right?
Yeah.
So in terms of all these smoking and all that, over long term, there might be some effect, but we don't expect the effect to be immediate. But for safety, in terms of anesthesia during the egg collection, that we usually advise them to, at least for smoking, it should be stopped.
Drinking as well?
Smoking, drinking, because all these might affect your general condition. But sperm does have bigger impact. So we usually expect men to refrain from all this before your IVF. And also, the other thing that to have better sperm condition, we usually advise our men now to have frequent ejaculation. So that whatever sperms that we're going to get on the day of egg collection will be new sperm, young sperm.
There you go, ladies and gentlemen. Myth debunked. So, Dr. Roland, I also understand that you also, input TCM, right, into your whole procedures.
Right. So TCM and Western medicine is really quite different. So TCM is, I would say, is quite parallel. But of course now, people are talking about quite a bit of interactions here and there. Because if you look at the development of TCM development is really based on what symptoms you have and then how I'm going to treat you. So there is a black box for the symptoms and treatment.
Okay.
Yeah. So this black box, they don't really look at it very much. They just say, okay, based on these symptoms, I have this treatment and it works. So a lot of this treatment by TCM is by experience. Whereas if you compare to Western medicine is very different because, it's very much based on reduction theory, whereby, let's say you have some liver condition. Liver condition, you want to look at the liver cells. You look at the liver cells and you find that, liver cells, there is some condition. There is a liver cells that is not so good. And so therefore, overall, the organ can't function properly. So this is what we call reduction theory. We try to explain a diseased organ based on the smallest unit. So it's a lot more convincing. Whereas TCM is completely different. Now, for fertility, I think TCM can be very useful in a few ways. There are a lot of things that are happening, like for example, some people have very thin lining, some people have very good embryos but no pregnancy. Some people have very thickened muscle on the uterus. But a lot of these problems, they have no solution in Western medicine. So we have to resort to TCM, whereby their approach is completely different. So we hope that the TCM physician will not be approached in the same way as what we do, because otherwise you're not going to find a solution.
Try different methods.
Different methods, because their approach has to... So let's say you are being referred to see a TCM because the uterus is swollen. I will be looking at, how is your menses. If your menses is heavy, then I'll decide what is your condition, whether it's because of excessive condition or deficiency in certain aspect in terms of TCM diagnosis.
Right.
And we treat accordingly in that manner. I will not be focusing on how to, reduce the size of the uterus. So in a way, so that's the main thing about TCM, because it does help to address some difficult situations in Western medicine that we have no answer to.
And so they'll take a different approach.
Completely different approach. That's what we need for a certain situation.
To
Because
see
there is
whether
no
they
answer.
can solve that thing on its own.
Yeah. because some of these conditions have no answer.
Yeah.
Okay.
Now, the other area where TCM will be useful for this, importantly, I think when you are going through infertility treatment, and that is extremely emotional and stressful period. So TCM, the good thing about TCM is it has a tremendous calming effect. So no surprise if you go for a session of acupuncture tonight, you'll sleep very well.
Okay. So help to reduce stress.
Yes.
So that means that I think very, very obvious questions that I'll probably asking now, right, is that for most in our today context, right, most of them couldn't conceive because of stress. And that is actually a very important factor in your opinion.
Well, I always say that, after checking through, so we have a lot of patients that have the same situations whereby you check through all the common, infertility indicators such as sperm condition, ovulation factors, fallopian tube, pelvis, fibroids, and all that. We check everything is normal. So we are having a lot of such situations now, what we term unexplained infertility. Yeah. So unexplained infertility, I think in a context Singapore, you can safely assume that it is coming from the stress.
Okay.
Yeah, because maybe your body is sensing the natural situation whereby you're just not ready for conception yet. Yeah. So one of the ways, of course, I think to keep it simple is for all our patients who are termed unexplained to move out of Singapore, go somewhere countryside.
Go Bali, relax, drink some,
but it has to be long enough. You need to be away long enough.
So how long is long?
Maybe 6 months.
Wow, that's long.
Not 1 week, 6 months.
Plant your own vegetable, rear your own chicken.
Okay.
So I think when you are away from that environment, that might be useful. But the other way, of course, we just had to, get ready and go for IVF. Basically, IVF, in a way, you facilitate and enable and allow things to happen.
So another myth that I'm probably curious about, right, is age, right? There are, I don't know, so far I'm hearing like 2 different age. One is after 30, one is after 35, the other one is after 40, right? They say that, people who after 40, they conceive is very, very extremely hard. They should go for IVF. In fact, that boils down to even 35, right? And the other one, why I say after 30 is that they say that it's best to get pregnant as early as possible. In fact, after 30, right, your eggs and all will deteriorate in a sense.
Quality of the eggs deteriorate.
How true is these statements?
So again, if you are addressing age impact on fertility, we need to first of all address another situation, and that is what is a natural fertility of a lady? How fertile is a person? Unfortunately, natural fertility is probably is one of the characteristics. Some people are just more fertile. Some people are just less fertile. So we always say that when you are 24, 25, you reach the peak of your fertility capacity. So let's say your peak is right there. Yeah. By the time you hit about 35, 37, some people say 37 is really not that important. I would say 37 because that's how IVF centers we publish our result, whereby when you are 37 onwards, your success rate is like that. So by the time you hit about 37, your fertility capacity is estimated to be half.
Half?
Yeah. So
Half of what? Half of the 25? Or?
Half of your maximum capacity.
Which is at 25, 26.
25. Okay. So let's say your maximum capacity is like that, and half will be like that.
At age of 37.
Yeah. But it doesn't matter, because if your maximum capacity is rather high, half you are still rather good.
Yeah.
But the main question here is that you do not know how fertile you are.
Yeah, you know how high or how low you are.
Yeah.
So if you happen to be like that, half you are touching the ground.
Yeah.
So really, I think the best advice here is, regardless of what people say, what 35 or 37 or 30 years old, it doesn't matter anymore. The real key here is as early as possible. So I think 30 will be the right age whereby you are maybe financially a bit better off, maybe a bit more independent. And of course, your thinking process might be a bit different.
So that's it. It means that the time that you freeze the egg is more important than when you conceive, right?
Correct, exactly. So I always say that the time-sensitive situation in our body, in the ladies, will be more of the eggs.
And when it was extracted.
Correct. And that's the only thing. Your eggs is time-sensitive. Anything else, the uterus is not. I mean, even if you are...
The guy's sperm is not as well.
Not as much. But of course, there are good evidence now to show that if you are after 40, the condition of the sperm will be lower. There is a lot more damage. So your chances of producing natural conception will be lower. Yeah, so it also matters to the guys, but probably not as much as in the girls.
Right.
Yeah.
Okay.
So when you talk about egg conditions at early 30s, 37, right? Talk about freezing and all. I'm curious now. Is there anyone that actually comes up to you and says, hey, actually, I want to freeze my egg, and maybe even to the extent where this is my future husband, all right, I'd like to do a pre-checkup, see whether or not this person is fertile, things like that. Is there such thing that comes to you?
Yes. Now, a lot of, we see a lot of couples coming forward to have a test for their fertility level and all that. So normally, with this situation, the first thing I tell them is that, before you started trying, there's no need to test, because the test result might show something that undesirable, and sometimes it's not very good for your journey to try for conception, because it might be too stressful. So I always say that the best example will be interpretation of a sperm result. The interpretation of a sperm result, whether it is a good sample or a bad sample, whether it can produce conception or not, it is interpreted with a background of trying to conceive without success. So let's say you have been trying for a year, then only it makes sense to go for a sperm test.
Okay.
Then the results will have some meaning. So let's say you try for a year without success and the sperm test is very poor, count is low and all that. So I can correctly to conclude that it is likely to be the sperm factor.
Right.
Now, before that, let's say you have not tried. The sperm count might be low, but it does not matter, because for all you know, your partner is extremely fertile.
Yeah.
The low sperm count does not matter. Yeah. So I generally advise...
You need two of them, the male and the female, to form a good backstory, right?
Correct. So infertility is always about couple.
Right. It takes two hands to clear the
Always,
shot.
yeah.
And so what role does technology now play in increasing the success of fertility as a couple then?
I think mainly the major development is in terms of IVF success and all that. So in a way, we are able to choose the right sperm, injection technique, different culture, media, culture, environment, how to have a constant environment all the time. So these are the areas whereby, there is major breakthrough, whereby the success rate becomes better and better.
I think just now we spoke about also in our casual conversation that the constant environment is a key factor, because sometimes the environment fluctuates, and because of that, the success rates change, right?
Correct. So environment is really important. So that was our second major objective of setting up a center. Our objective of setting up a center that whereby we could try to, as much as possible, we keep our success rate at a high level, consistent. So in terms of a laboratory side, the conditions of the laboratory become so important. We need to make sure that the condition from now and the next month and then another 2 months later is going to be the same.
So what's one important condition that it's important to fertilize?
So the lab technology has gone on so much. When we first started the lab, we actually have a very strict control, such that, I think there are a few things about the lab whereby it is a contained kind of a space. Whatever that comes in, whatever that goes out is under strict control. The other thing is that, from the storage space moving out radially, you're expecting the highest pressure from within the core, and then it slowly moves out. So in that case, you never get anything coming into the place where it matters most. It's always coming out.
Right.
So we have our pressure maintaining doors and all that, whereby you can only open one door at a time, for example. Yeah. So these are all the lab technology whereby important to maintain the environment.
And how about I think in our journey, there's also a look at how the eggs are extracted. Will the skill of the doctor play an important role?
Okay.
Or even technology used to extract?
Yeah. Well, there is individual ways of different ways of how doctors extract eggs, but I think over time, I think this is probably one area that might not be that important because if I do it certain way and I'm expecting 10 eggs, I only pick out 5. Naturally, the next time you will start looking at it how to make it better.
Right.
So it is something that it could be self-improve. Yeah, I think the main difference in the lab is really down to your live birth rate, your embryos grading at the end, because that is not up to you. Because you can't even looking back at your processes and all that, you can't even tell where has gone wrong.
Yeah.
Right.
Yeah. So the egg collection part probably not so much. Now there is another area that have not been highlighted very much is indeed in terms of timing. So like for example, I would like my patients to have injection at a certain time of the day. I would like to use a certain combination of medication and all that. And somehow this might be important in terms of producing the best condition eggs for the lab. Yeah, because different people might have different practices. It all depends on what they are taught to do so.
So how about the classification of embryos? I think this is something that is always talked about.
Correct.
And maybe you can shed some light on the various classes.
The grading.
Yes, the grading.
Yeah. So we never like to talk about all these gradings are like 4AA, 4B, 4BB, that kind of thing. We never like to
The
talk.
4 is like the days, is it?
Okay. So it starts out with a numerical and then 2 alphabets.
Okay.
So the numerical basically tells us about the size of the embryo.
The size.
And in this case, it's not any embryos. These are the grading that's only applicable to blastocysts,
Okay.
which is a special stage of the embryos whereby they are about to, or rather they are ready to go into implantation. All right, just before hatching. So the numerical is the size. So it can be 3, 4, 5, and sometimes 6.
Is there a good science for that? Or it doesn't matter?
Good size. Good size will probably be 4 or 5. 3 or 2 might be too small.
Too small.
So that will tell us about the potential of the embryo sometimes. Then the first alphabet is what we call the inner cell mass, the ICM. The ICM is supposedly to develop into the fetus.
Okay.
And then the next alphabet is the trophectoderm, which will supposedly to develop into the placenta, the membranes. So we don't like to talk about this grading as indication of quality. I always just say that it's a grading because I think the real application of this is really in terms of ranking of the embryo. Meaning if you have 3 embryos, A, B, C,
which one to use first?
Correct. Because one of our maybe indicator for performance would be how soon you get pregnant after IVF starts.
How soon you get pregnant for IVF starts?
Yeah.
Oh, okay.
So we will not want you to transfer your 3rd embryo then when you get pregnant. I would like you to be pregnant on the 1st embryo that was transferred.
And have you seen cases where the first embryo, which is with respect to the grading, the highest ranked, it fails, and then the 2nd or the 3rd one
very
successful?
Often. Very often.
So actually the grading is
with best intention. So it's not foolproof. So in fact, I think earlier Dr. Liao was talking about this embryo testing, PGS,
PGT.
PGS. So in fact, if you look at it in a strict sense, PGS only adds into the ranking process. He probably talked about AI, application of AI in the lab.
Yes, he
That
did.
is also part of ranking exercise.
Ah,
So as an embryologist, I might rate it as 4AA, but I have 3 other 4AA's embryos.
Right.
So which one go first?
Then your next test will come into play.
So this AI assessment, because AI will probably come in and say that, okay, A, B, C, D, they're all 4AAs, but they have different score.
right.
So there might be score 0.85, this one 0.76, So the higher score is closest to 1, that one will be ranked higher.
Yeah, so to our viewers out there, in case you're wondering what did Dr. Roland say, right? Go and watch Dr. Liao's episode. You will understand there.
Yeah.
Yeah. So when you come to all these things, I'm very curious because I think most people come to you with very, very low knowledge or in fact, Google knowledge.
Yeah.
Right?
Yeah.
What are some things that you hope that they know before coming to you?
Well, I think a very tough situation because, information is all out there, but we can't really control information's, outreach to our people. So a lot of them, they have their own opinions, information, base when they first came to us. So some of these informations can be quite difficult to unlearn.
Okay.
Okay.
So it's very difficult. So
Biases that you have
so a
gotten.
lot of them have their own idea of how things should be done.
Yeah.
So one of the things that we keep reminding our patient is that I think when you are here, you need to be convinced that this is a place for you. Our objective is all the same. Very simple. Our objective is for you to get pregnant, successful as early as possible. That's all our objective. So actually, it's important for when you go and see a doctor, whoever, I don't mean any Virtus or myself or whoever. I think whoever doctors that you see, it's important to place a trust. Because after all, these people are really in the field for long enough. They should be the best person to advise you. Whatever that you learn on Google is probably overnight or over the last 2 months.
Yeah.
But it is still not enough information for you to make a decision. Yeah. So it's a tough situation.
So how did your team actually, walk through the patients throughout the whole journey?
So I think with all this preconceived information and all that, it is a tough one. But I think we have to be very patient. So we try to, explain to them, why do we think of it this way and all that. So a very simple example would be, we have patients coming asking, doctor, why do you have to do blastocyst all the time? Yeah. So that's a very common question. My doctor is actually advising me to do day 3.
Yeah, day 3 embryo, right?
So he said that my doctor said that day 3 embryos is the best because if you are going to continue to culture, extend your culture, there's a chance that you might not have any embryos. And the best incubator for the embryos is your uterus. Now that might be true in those days, but certainly now with all this global experience and also our own experience, we have come to a conclusion that embryos to be transferred has to be the blastocyst. 2 main reasons. Number one, the incubator, I think the laboratory is probably a more consistent incubator based on what I discussed about the laboratory standards and consistency and all that. Because whereas it's expected to be maybe even better than your body environment. Yeah.
I mean, your body environment is the most natural environment, right?
Most natural environment, but
inconsistent, right?
Yeah, correct.
Inconsistent.
Yeah, you might be having some durian feast overnight and your body condition, acidity, pH and all that all change. Yeah. So that is probably not the best thing to do. Secondly, embryos at day 3 is never meant to be in the uterus. Because if you look at the natural development of the embryos after they fertilize, at the tail end of the tube, then after they fertilize, they take about 5 days for it to reach the cavity where it is ready to be implanted. So by day 3, they're probably midway in the tube. So you are going to put it, you just imagine this, if you are going to put your day 3 embryos in the uterus, in the cavity, this embryo will have to stay in that state in the cavity for the next 2 days. Yeah, floating around. I always say it's like, your hotel is not ready, but you got to wander on the street.
Wait for the check-in time.
You can't check in.
Yeah, you can't check in.
So that's the part. So there might be, in fact, if you transfer day 3, you might be wasting your embryos. Yeah. So those are the situations whereby, all this preconceived knowledge sometimes might not be that suitable because we know what is the success rate like. When we first started doing day 5, we also have our reservation. We also have our concern. But I think once the results, 1 year, 2 years down the road, we never look back anymore because the success rate is just so much different.
I think what doctor is trying to say is that because of research, in the internet and all, some people will say, day 3 is better, day 5 is better. And then because of whatever they read in those camps, they choose that particular camp.
Correct.
But if you choose a doctor, subscribe fully lah.
Yes,
Don't
of course.
subscribe
You have to. Yeah.
when we go for Chinese dinner, right, we must eat finish a full course, right? We cannot choose that, I just want to eat this course and run, right?
Yeah.
And I think that's key, you subscribe to the doctor fully and his philosophy.
Yeah.
Yeah. So I think Virtus focuses on the blastocyst phase, which is day 5, right? Day 5. Okay.
So maybe I'm curious here. Okay, I'm gonna ask a very results question here, right?
Yes.
Whether or not for you. So how many babies have you, successfully delivered over the last throughout your whole career actually?
Wow, whole career. Too long.
Too long.
Rough number off the top of it.
Never really talk about it, but I think every year we'll be looking at easily maybe about 80 to 120 babies in the market.
Wow, so you definitely have 1,000
Personally
over.
for yourself. Okay.
Yeah, wow.
So I mean that will be even more if it is the center. But I think for myself, I think for the last, at least for the last 10 years, that has been the number.
So there you go, ladies and gentlemen. That's why you have to subscribe to the doctor fully. It's experience.
Yeah, I think something interesting to note also is that Dr. Roland does not deliver, right?
Well, I've been doing full-time OB from beginning of my training all the way till 2017. 2017 because Virtus, getting more and more work done, and I really want to focus very much on fertility work. So 2017, I delivered my last baby.
17.
2017.
Okay.
Wow.
So then the work is just focused on
IVF and reproduction. So I'm dealing with a lot of other situations like ovarian cysts, endometriosis, as well as uterine fibroids. So these are some of the conditions that even before you move on, some of these patients that if you just treat these conditions, they get pregnant naturally.
Okay.
So it doesn't mean that all patients that come to us, they will require IVF.
Okay. So you still deal with the surgical work with regards to those fields?
The woman disease, gynecology aspect.
So help me understand here. So you deliver your last baby, you do the IVF, and then what happens next? That's only what, first trimester?
Right.
Or
So after the embryo transfer, 2 weeks later, pregnancy test, and then we do ultrasound to look at for heartbeat. Another 2 weeks later. So by then, when they come back for the ultrasound, they are all about 6 weeks. 6 weeks. So 6 weeks is probably about the right time that we start to see heartbeat. Now, from then on, you'll be just monitoring to make sure that pregnancy is going well, heartbeat maintained. And this medication I usually maintain up to about 10 weeks, 12 weeks, of which I will stop the medication and then I will talk to my patients about screening. Screening for Down syndrome, screening for fetal abnormality. And these are called early first trimester screening. Usually involves blood test and ultrasound. Now, I will go through all these results when the results are available, probably about 14 to 15 weeks. And after we've gone through the results, all happy, good occasions, then we'll say graduation, and they will move on to their own OB or gynae doctor to deliver them. So that's what I do now. So in a way, I used to send it off earlier, but it was a bit more difficult because some of our patients indeed encounter issues, especially in the screening part. So I found it, might be most appropriate if I talk to them first, just in case if there's any issue.
So some of these issues that surface in that first trimester would be screening for Down syndrome and any abnormalities, right?
Correct.
And does Singapore allow us to screen that in the embryo stage?
Okay.
Is that possible medically?
No, of course it's done everywhere. So
Okay.
I think that's exactly what we talk about PGS, pre-implantation, before you implant, genetic screening.
Okay.
So the other term now, the newer term is called PGT-A. That means pre-implantation genetic testing for aneuploidy. Aneuploidy, basically you look at whether the chromosomes are balanced. Yeah. So at the moment, this is not allowed in Singapore. I think, in public hospital, they are talking about research stage and all that, but up to now, nothing has really come out of that. But, around us, people are all offering it. Now, the main issues about this pre-implantation genetic testing is that it's not so reliable yet. The technique is there, but it's not so reliable, and there's a lot of many factors that's involved here. So for those people who are looking at screening, I always talk about balance between two main factors. The people who I will say, or you might consider screening if you had miscarriages or pregnancy failure, and you want to minimize this. However, on the other end of the balance is that you haven't gotten any live birth yet, and you want to maximize your chances of live birth. So you have to see what is more important to you. Now, we understand that miscarriages, pregnancy failure, especially in the first trimester or second trimester, is something very emotional and stressful. Yeah, so a lot of people, never get recovered from that. They get scarred, they emotional. So to some people might be important, but you have to understand that you have to balance this to your chances of live birth.
Right.
Now, when you're going for screening, because of the test condition, the nature of the test, it might jeopardize your chances of live birth. Yeah. So you have to see the balance. So this is how I tell my patient about screening, because of course you talk about being not allowed in here.
So now that we talk about technology, right, I'm curious, what do you think is the biggest breakthrough in the fertility treatment that's going to happen next then?
Interesting. Yeah. Well, it's very likely to be along that testing.
Okay.
Because I think as much as possible, if let's say if we can overcome that problem of miscarriages, unsuccessful transfer, because even now with the best situation, the best embryo condition, best embryo grading, best environment, we are only talking about a success rate of about 50% up and down.
Oh, okay.
Per
50%.
embryo.
Oh, okay.
Embryo transfer. Okay.
Per embryo.
Okay.
Yeah. It's only that. So I think we need to have a major development here. I hope that is coming, but it doesn't look very promising though. Maybe not another 10 years. But I think this will be some area that is really necessary to be developed. Now, we also feel that, the PGTA might be the answer. Could be. But PGTA, I think importantly, if you look at PGTA, it does not give us a better embryo.
Okay, yes.
I think that's a very, very important question, area. Because you might do all the screening that you want. It basically just tells us what is the possible outcome of the embryo transfer. It does not. So
It doesn't
improve the
increase
chances,
results, nothing. Yeah.
you are just doing a test on what is available,
Yes.
Yeah.
You think in your medical acumen, there will be a chance that we can improve the chances?
I'm sure there is. Yeah, I'm sure. So currently, I think, the lab and myself, we feel that, they are basically, to have a successful pregnancy, they are basically just two processes. One is how is the embryo condition? Two is how is the implantation? Right? So probably the embryo conditions are still probably carry about 90%. Yeah, we don't really think that the implantation part is very much. So I think it's also important to appeal to our people, our patient that if you have IVF failure, 90% is due to embryo. But however, it's not so easy to convince, because most people will straight away come to a conclusion that it's because I'm weak. I'm weak. I'm not good enough because I had a near fall. I went traveling. Because I went on some scooter or some water ski.
Some adventure sport.
too much durian.
Pineapple.
Pineapple, yes.
Yeah. So I think this is very
Drink cold
important.
water.
Yeah, because you see the self-brain starts to set in very fast. So it's not very useful. We do not want them to feel that way. So over the years, I think our major focus, at least for my clinic, our major focus is just, when you fail, I just want to focus all my attention on getting better embryo.
Okay.
Of which better egg, better sperm, better source of sperm, or different stimulation method, so that we can get better eggs.
So do you foresee that, these treatments will become way more accessible, right, and more mainstream, even though with normal conceive and all?
Yes. Naturally, if you look at natural epidemiology and all that, right, as a country advances, economy becomes more advanced, or naturally fertility level will drop. Yeah. So of course, it takes a lot of effort to reverse that, and efforts in terms of community measures, giving more rewards, giving more
Tax
money.
savings.
But giving
More
more
leave,
money, giving more money is not so simple. I think it's probably multifaceted. You have to look at how to improve their work condition, work-life balance. You have to look at the child facilities.
Yeah, child facilities. That's the long-term
Correct.
solution,
These are
right?
long-term. So if I could promise all or everyone that, just go ahead and reproduce or procreate, all this will be taken care of. I think that would be a significant injection to confidence
Right.
of people to reproduce. But otherwise, with advanced technology, advanced economy and all that, we expect the population to shrink.
So on that note, I have to ask this question for you people out there, right? Let me bite the bullet on this. There's a myth that's saying that, once you gave birth to your first kid, it's best to go back to back. Is it true?
Not so. So when somebody come to me and ask, doctor, what's my chances of fertility treatment? The first thing I will say is age. The second thing I will say is, whether you have been pregnant before. Yeah. So age, we mentioned a lot already about how fertile you are and all that. But whether you have been pregnant before, why is it so important? So it deals with a lot of situations whereby we still do not understand why certain couples, certain patients just don't
get pregnant.
Don't get pregnant. So the moment you're successful, it tells us that implantation is no longer a problem. Yeah. So there might be, we say 10%, that 10% could be extremely difficult to handle.
Right.
Yeah. So once you are pregnant, the chances for you to get another pregnancy is already quite, can be safely assumed. It's going to be a lot easier. So if you do not get pregnant, thereafter, after one pregnancy and delivery, I just need to focus on how to get the best eggs, best embryos, and I know that it's going to be successful.
I think this goes into the realm of whether it's an infertile situation or subfertile situation, right?
Yeah, correct.
Yeah.
So second degree, we call it second degree infertility, is never a big problem. The primary infertility could be potentially tricky.
I see. So second myth here I'm going to ask, okay? I know just now they were talking about it, right? You're hoping that they will ask the questions, but let me ask it for you. We talk about cold water. We talk about pineapple, right? All these myths that, that's why you don't get pregnant and all. All wife myths, right? How true?
Very interesting. So I got to wear different hats when I answer this question. So if I'm wearing a hat of TCM, I will say, now, just now I explained how TCM theories come about.
Yeah.
A lot of this is due to experience. All right. So experience, it must have some basis. So people who had, taking pineapple, for example, there might be some adjustment in the body that is necessary in order to counteract the effect of the fruits and all that. So all these adaptations and adjustment and all that might have an impact. Cold water, it might actually affect your energy flow and all that. So there might be, because the experience has been going on for years.
Right.
We are not talking about decades. We are talking about, from old days of Lao Zhong Yi and all
All
that.
the way until here.
Yeah, until now, And naturally, our ladies will be able to tell you that when you take cold water, you're going to have more menstrual pain.
More contractions, right?
Yeah, so there must be some basis of it. All right. However, if you are looking at the Western medicine point of view, our body is way, way better than that. Because, that's how we have advanced till now, where so many generations has gone through. I think one of the major ability that we have is the ability to adapt. So I always say that I can have a pregnant mothers. Today, I bring her to 3,000 meter above sea level. And then tomorrow, she had to give birth. Her baby will be in trouble. Yeah. But if I had brought this mother and stay at 3,000 meters above sea level for the next 3 months, and then she deliver, baby will be fine.
The adaptation and
Adaptation.
all.
That's adaptation.
Right. So there you go, ladies and gentlemen, right? Dr. Roland on the house. Dr. Roland has debunked these myths for you. Yeah.
There's one more question I wanted to ask also, which is from the extraction of the eggs, the harvesting of the eggs, right, until the transfer. I think some couples will think that, hey, I want to do it immediately. So maybe you can shed some light on what's the consideration for this period of time.
So immediately meaning doing fresh embryo transfer.
Either fresh embryo transfer or immediately the next month.
So next month is fine because what we advise is that as long as you do your embryo transfer, not within the same month as your stimulation for your egg collection. So that will be fine because what our main concern is that your body is still having this high hormone level, and so therefore your lining might be not in sync with the embryo stage. So your success rate will be lower. Furthermore,
It's proven, right, that you will be lower.
Yes. Good evidence to say that your obstetrics during, that means complications during pregnancy, like bleeding, premature contractions and all that, will be more. So that has all been proven. Now, so that is one aspect. The other aspect is, of course, the intention to do this really is for higher success rate. Yeah. So the success rate, as long as you don't do in the same cycle, your success rate will be better. So I'm not too concerned about, when 2 months, 3 months, next year. It doesn't matter because as long as the embryos are there, as long as you don't put in the embryos at a fresh stage, it will be okay. Yeah. So it has already well shown that, the pregnancy outcome, obstetric complications is less. The other thing is that we find that patients are also extremely receptive to it because, going through the process of egg collection and medication and all that, right? You are constantly being worried about how many eggs you're going to get, how many embryos you're going to get. And now you straight away have to go into this stage whereby you're going to worry about whether implantation can happen, whether pregnancy can happen. It's just too stressful. So all these are multiple factors. I think the main reason, of course, the number one priority, main reason why we want to do frozen embryo transfer is for safety because of this OHSS, ovarian hyperstimulation. If you put it in, they get very bloated, they need to be in hospital, drain out water. That was the primary objective. But eventually with this, in order to avoid this objective, we do frozen embryo transfer. And that's when all these additional benefits start to surface. Yeah. So, in a few years before 2015, when we were in other centers, when we were doing all this, I started, myself and Dr. Liao is probably the first few people we started freeze all. Daringly, we just put our foot down and say, we tell patients that I think this is better for you. We freeze all. Outcome, I'm not so sure yet, but I can assure you it's going to be the safest way of doing IVF. So we put our foot down and then we freeze all. And then the following month, they come back and transfer. And success rate is just wonderful.
I see.
And at the same time, also the rest of the world also start to show that it works.
That's the way it is.
That is the way to work.
On that note, I'm curious. So, what's one change that you hope to see in terms of public awareness or even policy around fertility?
I think the most important, in fact, is really to start as early as possible. Because if you look at the success rate, all we have, a success rate of IVF centers is presented in category of age. So we have less than 30 with 31 to 37, 37 to 40, then 40, 41, 42, 43. The massive drop is actually not so much at less than 30. Less than 30 and 30 to 37 is about the same. They are not very much difference. But once you hit about 37 onwards to 40, it is a major punch.
Wow.
Yeah. So similarly, I think the other issues that most people will be looking at is, I'm 45.
Yeah.
I just found a man that I got married. I want to do IVF. Yeah. But then, I can produce eggs. It does not matter. My success rate should be okay. but the result does not show so. So that's the most cruel part of this IVF treatment. Because as long as you are beyond certain age, let's say 45, the chances of pregnancy success is extremely low, regardless of the grading of the embryos, number of embryos.
Okay.
Yeah.
So that's why you say that as best as possible, get the eggs.
Freeze
Egg
earlier.
freezer, freeze the eggs and start early. Yeah.
So I have a lot of questions that I actually want to ask Dr. Roland, but I think we take up quite a lot of time, right? In fact, I'll invite you for another podcast session just to talk about all this. But before we end today's show, right, maybe I put your attention to this camera here, right? Any last, advice, tips, right, to all our viewers out there?
Well, I think important message, if you are single and you are not about to be trying for pregnancy, I think it's important to consider egg freezing. I think this is a very important message. Secondly, if you are married and you are ready to start a family, regardless of what other considerations, should start early. Should not wait. Even if you decide not to start early, please freeze your embryo first. Thank you.
There you go, ladies and gentlemen, Dr. Roland.
Thank you. And that wraps up our Heart to Heart with Dr. Roland Chieng, who reminds us that science, compassion, and a little bit of hope can go a long way in creating life's most precious gift. Whether you're just starting on your journey, supporting someone on theirs, or simply curious about what the future of fertility looks like, we hope that this conversation gave you new insight and inspiration.
A big thank you once again to Dr. Roland
you.
for not just sharing his expertise, but also his passion and humility. So until next time, keep asking those big questions, keep dreaming those big dreams, and remember, every journey has a beginning. Hi guys, thank you for listening. If you like what you have just heard, follow us for more content like this.